skin cancers. What are the types and how to identify them? I am Dr. Sheila Farhang. I'm a board certified dermatologist, skin cancer surgeon, and cosmetic surgeon. And skin cancer surgery, specifically Mohs micrographic surgery, is a big part of my practice and what I do. So, and especially living in Tucson and also having a practice in California, this is a very big part of my practice. So I'm going to kind of lay down what to look for non-melanoma skin cancers as well as melanoma skin cancers, your risk factors, what your dermatology appointment can look like, and some of the kind of treatments that we do for some of these. So number one, the most common type of skin cancer is non-melanoma skin cancer. These aren't dark moles. These are actually typically pink, scaly. They can be completely asymptomatic, which means they don't hurt, they don't bleed. Sometimes they will if you rep them. So with non-melanoma skin cancers, they're split into really two main types that are the most popular, and that's basal cell carcinoma and squamous cell carcinoma. So let's start with basal cell carcinoma. It's one of the most common, and this can happen as young as people in their 20s, and I've done skin cancer surgery as young as people in their 20s. These, we say, usually come from like really bad sunburns that you had as a kid or a teenager. And these are really, really kind of difficult to see because they usually are not scaly. They almost look like a pimple. My usual thing when I tell patients is if you have a new red spot, it doesn't necessarily have to bleed or be irritating or anything, although sometimes typically that, they can be. If I ask patients, oh, is there a spot on your face where you're, drying your face after washing it and it kind of bleeds a little bit? If they tell me that, and they're not like picking at it or anything like that, it's usually a time for me to like really look at it with my dermatoscope, which is a little light dermatologists use to see a couple like red flags. Like we look for things that each skin cancer has with their light. So for basal cell, for instance, there's a specific blood vessel, and there's just a couple signs that we look at, and that's why we use our little light. So basal cell carcinomas, bad news is they're really hard to find, so definitely see your dermatologist. But if you have something like a pimple that just popped up out of nowhere, like a red spot, looks odd, but it's not going away for a couple months, that is a time to get it checked out. The good news about basal cell carcinomas is they have a very low mortality rate, which means they don't spread and metastasize typically, and they are very slow growing. So usually patients will be like, oh, it's been there for like 6 months, a year, something like that. And it's still relatively small and manageable. The big issue comes in when it's been like 10 years or something like that the patients thought it was ringworm or something. I just had a patient that I just did, and I took out what was like the size of like a lime or a lemon. It was pretty big, and he had it there for years because he thought it was ringworm. So that is one thing. If you have a spot that's not healing over the next, over months, that is the time to get it checked out by a dermatologist. Squamous cells are very similar. They are a little bit more high risk, especially in the face area, like head and neck area, like the lips and the ears, because those can spread. Of course, they can spread anywhere, but if you have it on your arm, they're like less likely to spread. But these typically can spread, and they can be very bad squamous cells. They are a little bit faster growing, and then with these, they typically have scale on them. So that's kind of something to look out for. If you have a new spot that's a little thick, a little indurated, and has some scale on there, and you're like, that's weird, definitely get it checked out, especially, if it hasn't gone away in a couple months, if you've picked at it and they came right back, that is the time to get it checked out. So with both of these, depending on where they are, the most kind of standard way to treat these is cutting them out. And if they are in very sensitive areas like the head and neck area, the palms, the feet, the genitalia, scalp, the ear, things like that, Mohs surgeons like myself do a procedure called Mohs micrographic surgery, which is a very specialized technique to take as little skin as possible. So it's very skin conserving. And then we do like a very delicate reconstruction to make sure that it's put together nicely, especially if it's on the nose or eyelid or lips or something like that, where there's not a lot of skin, because then we have to do sometimes flaps and grafts and things like that. If it's on the arm, then we do a standard excision where we take a couple millimeters around, do a football shape, and typically the line scar is a little bit longer, than the actual skin cancer there. But That's usually the treatment. For excisions, we say it's like a 94-95% cure rate. For Mohs micrographic surgery, it's a 99% cure rate because we see like all of the tissue around there. And then you really don't have to worry about that spot. You have to worry about new ones because sun just didn't hit there, it hit everywhere. So we have to monitor you every 6 months. So that's non-melanoma skin cancers, right? Then we have melanoma skin cancers, which are more genetic. The other non-melanoma skin cancers are not typically genetic. They're only genetic in the fact that if your parents have fair skin, you have fair skin, you lived in a sunny, beachy area, that's how you would get that. That's like passed down to you in an area where you have really fair skin. With moles, so melanoma, that can be very genetic, so you don't have to have a history of tanning bed use or anything like that, although that increases your risk of melanoma. This is something where if you have a family history of melanoma, if you know you have something like the BRCA gene mutation where you have a history of pancreatic, breast, and melanoma in your family, that could be linked together. So it's really important to get monitored if you have that gene. Usually people get bilateral mastectomy. It's also really important that you get your moles checked. The number of moles. So if usually people have more than like 75 moles, you're just really moly. There's a chance your body could mess up, especially if you had a lot of sun exposure, and the more moles you have, the more likely one could mess up, and it could be a little bit more atypical. In this realm of moles, there is something also called dysplastic or atypical moles, and this is a benign mole. It just looks really atypical under the microscope, where it's, the cells are larger, they're jumbled, and this is something that is a risk factor for developing melanoma. So just in case you've had that, that's what that is. And if it's mild, usually it's mild, moderate, or severe. Mild, moderate, we like to shave it off. Severe, we like to cut it out. With melanoma, of course, if it's caught early, so if you have a lot of moles, you got to get it checked out. I would say come see a dermatologist, because you don't know typically if your moles are changing. We just have to look at them all. Of course, after the age of 30, that is when all of your moles have shown. So before 30, you could still be like born with a mole that hasn't completely showed itself. But after 30, if you get a new dark mole, that is something to look out for. And then of course we see the ABCDEs of mole changing. That is important, but in my office, I've seen a lot of moles that really don't look that different or that obvious. Of course, I can show you a few that really look that obvious, that they have the asymmetry. So the ABCDs are basically asymmetry. The borders are really irregular. C is color, so there's a little like blue tinge in them, a black, a brown. They're not like cohesive. D is diameter, where it's like more than a pencil eraser head. E, evolution. So that means it's changing. So that's really important. But for people that are really sun damaged, history of tanning bed use, I go through and we look at all their moles. And sometimes we find atypical ones, and we got to really keep an eye on them. And oftentimes we'll see some melanomas. And again, if it's caught early, and that means that it is still less than 1 millimeter, hasn't passed that 1 millimeter depth, then we don't have to send you to the cancer center to get your lymph nodes checked, because at that point there's a much higher risk of metastasis, and that's when it gets a little bit more serious. So if you have a family history, lots of sun exposure, lots of moles, lots of sun damage, you live in a really sunny area, definitely get your moles checked. This is something that's covered by insurance if you have it, and it's a very easy process, especially, if you want to see if you're a female, you want to see a female, you absolutely can. If you're a male, you want to see a male, you absolutely can, just to make it a lot easier for you. I don't typically look at people's genitalia unless they have something there, so you definitely don't have to have your dermatologist look at that if you're really worried about it. But I do like to see around the chest area, but you can, of course, if you don't have anything there, kind of like not have me look at those areas. But it's a very easy thing to do, so don't be scared of it. We don't care if you haven't shaved your legs or anything like that. We're just looking at your moles very objectively with our little light. So hopefully that sheds light on skin cancer, the types, how we treat them, as well as what it's like to see a dermatologist. Leave your questions down below, and like, follow, comment for more. Thank you.